Thank you, Mr. Chairman, ladies and gentlemen. Well, we've got one lady who's not there anymore. Right, so we've heard a lot about acute ankle instability. We've heard about unresolved ankle sprains. We do know that some of these will go on to become unstable ankles, and how do we deal with that problem? So chronic instability is a known entity in foot and ankle world. And we know that majority of these get acute ankle sprains on the lateral side, a minority do on the medial, and increasingly we're becoming aware of medial and syndesmotic instability. You might have a patient who has joint laxity who has more than one of these in one patient. So I'm going to go back to medical school here really, and we're going to recollect some of our anatomy from the dissecting days, and I don't know whether you remember, I can't, certainly. So I'm going to go through some of the ligaments that we should know about. So anterior talofibular ligament, which is the most commonly injured in lateral ankle sprain. Calcaneofibular ligament, which is obviously the second most common, and posterior is the least common. We're also going to look at the syndesmotic ligaments. So you got the anterior inferior tibiofibular ligament, and then you got the introitius in between, and at the back you got the posterior counterpart of that. And there's introitious membrane which goes in between the tibia and fibula. And the medial side, you've got the superficial deltoid and the deep deltoid. And all of these you can see pretty much on an MRI scan on an axial view. In addition, it's all been highlighted that ankle sprains can have associated injuries. So it's important to recognize where these other structures are, okay? And that gives you an idea where your pain might be coming from rather than just the instability of the ankle, which may be completely pain-free in between. Okay, so peronei classically will be on the outer side, and you can see them on the MRI scan in an axial view. And the joint, subtalar joint instability can be associated or is associated with a lot of ankle instability. So you might stabilize the ankle thinking that the subtalar joint is going to be okay, but they might have isolated subtalar instability and pain. Okay, why do we get instability? We get instability, we talked about inadequate rehab sometimes, which can lead to loss of proprioceptive control, loss of neuromuscular control there. We might have biomechanical issues with the hind foot. We might have pathological laxity or hyperlaxity of the joints. And the pain usually is due to intra-articular lesions, and they can be in almost 23% of your ankle sprains that we treat. So be vigilant about those. How do ankle sprains occur? We've already highlighted that. The key is this is a sequential failure or ligaments on the lateral side, and the gradings are pretty straightforward. So we're going to recap. ATFL is the weakest. CFL is 3 times or 3.5 times strong. Stronger than ATFL, but that PTFL is the strongest one. A deep deltoid is crucial to the medial instability, and syndesmotic ligaments may be injured without having any bone injury, and that we'll come to that in a minute. Okay, there's a concept of mechanical versus functional instability. The mechanical one is obviously you move your joint beyond the physiological limit of that ankle joint's range of movement, and that's your mechanical instability. But sometimes it's the subjective feeling. So when you're examining your patient, and we'll come to that in a second in your stability testing, your patient may not have a classic anterior draw, but will complain of subjective feeling of ankle feeling unstable, and that's usually due to the proprioceptive or neuromuscular deficits. But usually you find a combination of these two, so look out for both. Back to basics again. I think for me, instability, you can just listen to the history from the patient and examine them. MRI pretty much is to exclude anything else inside the joint or outside of the joint which might be contributing to the pain in addition to the instability. So that is how I see it. Okay, so there's no going away from having to do a good history and examination here. That's the point. And I've sort of highlighted these points, and we'll go through them one by one. This has been already alluded to, and I reiterate, look at the back part of the hind foot. If it's in cavo varus, whatever you do for the instability, for stabilizing, it's not going to be good. So do correct that at the same time. Do know where your surface anatomy is, okay? So where the ankle joint is, where the talonavicular joint is, subtalar joint is, and I've sort of highlighted that here, okay? So they're different only within a centimeter of each, but you can differentiate those. So know your surface anatomy. Do your stability test, and the one I rely most on is the anterior drawer test, because talar tilt can be negative in almost sort of 50% of your patients. But compare with the other side. You've got two ankles, okay? So if you are doing one ankle stability test, you've got to be comparing with the other side. And there are various ways to do anterior drawer. For me, what works best is this, okay? And that is a grossly unstable ankle, and you can see that. Sometimes you might not have that sort of instability, and you have an impingement, and Albest has already talked about this, you know. Injecting a local anesthetic in that area might give you your diagnosis that this is a synovitic impingement in the front rather than having a true bony impingement. This is a member of staff who came to see me last week who's got a high ankle sprain or a syndesmotic sprain. They point the pain to a different area, to your lateral ankle sprain, and you've got to be vigilant. This is all clinical diagnosis we're talking about. Okay, the syndesmotic squeeze test, not 100% specific, but can give you a clue. If you bring your tibia and fibula together and they are getting pain more in the anterior aspect of their ankle, they might have an unstable syndesmosis there. You've done your plain radiographs. Look for any clues if they are giving you. Majority of the times, plain radiographs don't show much. So stress views in my own practice have a very limited value. And I only do them either under GA when I'm not very sure what's going on, or at least put a local anesthetic in for them to be able to bear the stress that you are going to get them through. So it does identify mechanical instability, but they're not particularly useful in my own practice, I find. MRI is to find other things. You might find the osteochondral lesion. You might find that you've got the ATFL gone there. MR arthrogram is useful for high ankle sprains. So, you know, if you are suspecting a syndesmotic injury, think about MR arthrogram. An ultrasound is useful. It's an easy tool to do for tendons, ligaments, and just sort of looking at the pathology around. So, management considerations. Everybody gets non-operative rehab properly. So work on their proprioception, particularly with the functional instability, work on their proprioception, neuromuscular control, and get them through a proper physio rehab. And think then, is this ankle still painful? If it's painful, get an MRI done. Is it unstable? If so, if you need to screen, you need to screen. But if you're clinically happy that this ankle is unstable, you've got to stabilize that. And deal with the pain. You can deal with the pain if there is no gross instability by doing just an arthroscopy, and we'll go through the setup this afternoon later on. And then it comes down to, you know, do you have to surgically stabilize this ankle? I'm not going to go through these because I think it's been covered pretty much in all other talks. But do look for associated injuries when you're planning your surgery. Okay, so tendon problems are common. Ankle scope, couple of quick words. You can do a lot with an ankle arthroscopy. Okay, so particularly in instability situation where you've got an osteochondral lesion associated with it, or if you're just dealing with a synovitis bit of it, you can easily do all these procedures under ankle scope. And it's day case procedure, and we'll go through the setup and video later on, but this literally is 2 small cuts and job done. And you can see variety of pathology here, and that's already been looked at. You know, big flap osteochondral lesion, you've got synovitis there. So then it brings down to the operating bit. The operating bit is 2 types. You can repair the ligaments with an anatomical repair, or you can go through the non-anatomic. For my practice, I would say majority, well, the first line of attack is repair. Okay, so look for stabilizing these by using the tissues they've got. And there's a variety of ways, and Mr. Best has already shown how small his incision was. Mine is probably half a centimeter more, admittedly. But what you have to look for is your superficial peroneal here and your sural here. And you have got enough space in between to work. And with the modification, you can get the inferior extensor retinaculum to reinforce, which is the Gould modification. And this is just an example of that. And there's a variety of ways. You can double breast, you can shorten the ligaments, but the key is to get what you get on the outer side of the ankle, stick it back onto the fibula, and get some inferior extensor retinaculum on. If you are having a peroneal pathology at the same time, then you can work with a longitudinal incision and do the both through there. I must say I've not done a lot of these because the Brostrom works so well and doesn't fail easily. So you can use peroneus brevis, split it like a Christman-Snook type procedure. And there are artificial ligaments on the shelf if you really are struggling as your third or fourth line. But we're not here for that. We're talking about basic stuff that we need to do. And this is your standard post-op rehab. They go into either day case procedure or overnight, and then the 2 weeks non-weight bearing for me in a split cast, and they start weight bearing in a cast for another 2 weeks, and they go on to an air cast ankle brace after that, where the rehab and physio looks after them. And I'll only see them at 6 weeks and 6 months, really. So a little bit about syndesmotic sprain. If it's unstable, you've got to fix it. And we talked about tightrope. Tightrope is a good technique to fix the unstable syndesmosis. If it's stable, you brace it for the time. And if you're getting pain just from the syndesmosis and everything feels stable, you could just do a scope and clean out. Okay. A couple of slides about medial ligament injury. I think it sees us more than we see it, if that makes sense. So essentially, we under-recognize this condition, and increasingly there is awareness that we have medial ligament injuries as well. It can be associated with your lateral side or syndesmosis, and the key is to understand the deep deltoid is crucial. As there's a classification, I wouldn't worry too much about the classification. What you have to see is if there's superficial incompetence and pain, you can get away with just repairing it. If it's completely gone on the medial side, you really have to think about reconstructing with either an autograft or some kind of allograft. Ligamentous laxity is a failure of the nature. It's not the structure of the ligament. So, and the proprioception is poor in them, and your surgical results are pretty unpredictable. So emphasis here is on rehab, rehab, rehab. Don't just jump onto these and repair, because they will not do very well. Okay, so we're just going to recap again. Most patients will have some element of functional instability with your mechanical. You must treat the pain first and stabilize, as in when necessary. MRI is good for looking for pain, not so much for functional instability, but for pain around the mechanical instability that you get. And scope is good. 75% of your patients probably will not need reconstruction because you're just in pain and not in mechanical instability. What we're trying to avoid is this situation. So your unstable ankle, we know, will lead on to post-traumatic arthritis, chronic pain in your ankle, and requiring bigger procedures. This is just an article. If you're interested for a review of this condition, I can pass it on to you if you are interested. Thank you very much. Now for the video, we'll show that in the video section, if that's okay.
Thank you, sir. May